Hello, everyone, and welcome back. I hope you all had a good break and benefited from all the different features on our platform. Welcome back again. This session on zero separation and family-centered care will be chaired by Sophie Janet. Sophie is a pediatrician specialized in newborn care. She holds a master's degree in international health and tropical medicine from Oxford University. She has worked with various organizations across Africa, Asia, and America, and is currently working as pediatric advisor with MSF based in Dakar in Senegal. Thanks, Sophie. Look forward to listening to the session on family-centered care and zero separation.
Thank you, Myrto. I'm really excited to be here on this session on family-centered care and zero separation. Person and family-centered care is one of MSF priorities to provide respectful, holistic, and quality care to the population we serve. This approach leads to better health outcomes, improved experience of care, empowers family, and wiser allocation of resources. However, its implementation in newborn care is hampered by the current health system status quo, which provides silo care for mother and their babies and systematically separate them directly after birth when requiring medicalized treatment, despite the proven benefits of keeping them together. The current health system paradigm underestimates the value and importance of the mother and baby dyad. And today, we're challenging this practice. During the session, under the umbrella of family-centered care, we will introduce the concept of zero separation with a short video. After, the team in Tanzania, who participated on the multi-center randomized control trial on immediate kangaroo mother care led by WHO, will present the findings of the study, followed by the experience of a mother and a nurse who participated in it. Next, we will have Dr. Barbara Moreno Sanz from Spain, who will share her experience on implementing and scaling up family integrated care in the neonatal intensive care unit of her hospital. And as a final speaker, we have the privilege to hear a mother from South Africa and the founder of a parent association for premature babies, who will share her experience and perspective as a mother. After the presentation, we will have a multidisciplinary panel discussion to reflect on the opportunities and challenges to achieve family-centered care and zero separation in MSF. As a reminder, you will be able to ask your questions anytime, and like the question of other participants. In view of the limited time, only selected questions will be answered during the panel discussion. But remember, you will be able to ask unanswered questions to the panelists over coffee at the end of the day. I really hope this session will inspire you and challenge us the way we care for mother and babies. Now, let's start the session with an introductory video that will take us through what exactly does it mean zero separation in MSF. Thank you.
What is zero separation? Zero separation means creating the best possible conditions for mother and babies to receive coupled care starting from birth. It is a concept that lies within the people or family-centered care framework, the needs-based approach, and respectful maternity care. It has different dimensions: proximity, physical and emotional, and integration of mother and baby care, which means providing care and responding to the dyad's needs at any given opportunity. It can be applicable at all levels of care and in any setting. A health system that embraces the concept of zero separation is designed in a way that reduces unnecessary separation of the mother and her baby, removing barriers that hamper proximity and integration of care across the continuum of care. During the mother-baby health journey, there are many opportunities to promote and strengthen the couple. For example, at birth, the mother and her baby should have the possibility to be together, starting breastfeeding and skin-to-skin as soon as possible. Neonatal units should be organized in a way that facilitates a comfortable and appropriate space for mother or other family members to be with the sick newborns and participate in their care. When providing care in the hospital, primary or community level, we could respond to the medical and emotional needs of the couple at the same opportunity. For example, when doing a newborn consultation, health staff could ask the mother on her nutrition, mental, and medical health needs, and vice versa. Zero separation is a call for action for all health workers to rethink the care they provide to mothers and babies. It can be gradually integrated into MSF operation and might look different in each setting. Why should a zero separation approach be adopted in MSF? During the early 20th century, when the birthing practice moved into hospitals, war routines separated newborns from the mothers and other family members directly after birth in most high and middle-income countries. Health systems were planned around the care provided, prioritizing practical organization aspects above patients' needs. For instance, it was easier for doctors to take care of patients without family around, and easier for a specialized team to work in silos. Since then, separated medical wards and siloed care for mother and babies became the norm, even in humanitarian settings. This approach to healthcare underestimates the value and importance of the mother and baby dyad. Today, we're challenging these inherited practices.
What are the benefits of zero separation? Ultimately, zero separation reduces mortality and morbidity. There is solid evidence to show that even newborns that are sick and unstable can have better quality of care if they have skin-to-skin contact with their mother from birth. It reduces complications such as infections, hypoglycemia, and hypothermia. Additionally, breastfeeding increases and the bond between the mother and the child is reinforced, reducing maternal stress.
It ensures that mothers are provided with respectful maternity care by highlighting that it is the mother's choice whether to be close to her baby or not, and her choice shouldn't be limited by how the health system is organized.
Partnership between the health staff and the caregivers is enhanced in taking care of the baby and its needs, with the added value of increasing the quality of care and reducing the burden of staff health.
Zero separation is an opportunity to carry out patient-centered care for mothers and their baby in our project. We can start by reflecting on the barrier that may come up in the project we work on to achieve zero separation. How can they be overcome from multidisciplinary perspective, including not only health staff, means nurses, doctors, midwife, also other profile like logistician, admin, HR, health promotion, mothers, families, and community, spread the word and start the change.
Contact your pediatric, sexual and reproductive health and nursing advisor for more information.
You has sparked your interest and you want to hear more. It is my pleasure to present Dr. Naomi Amond, pediatrician at the Muhimbili National University Hospital in Tanzania, who will share their experience on their participation in the immediate kangaroo mother care study, followed by a mother and a nurse testimony. Over to you, Dr. Naomi.
Hello, everyone. Thank you for listening. Now, everyone's
We cannot hear you, Dr. Naomi. Are you there?
Yes, I'm there. I just setting my shed.
We're just arranging a few things.
Yes. Okay. So, hello, I'm Dr. Naomi Mamaneke. I'll be presenting immediate kangaroo mother care study that we did. Tanzania being one of the sites. Hello, everyone. I'm Dr. Naomi Mamanenge. I'm a pediatrician. Currently, I'm doing Masters of Clinical Science in Neonatology at Muhimbili University of Health and Allied Sciences. Today, we're going to talk about immediate kangaroo mother care, a study that was done among 5 countries by WHO, and Tanzania being one of the sites. So, introduction. WHO defines kangaroo mother care as the care given to preterm and low birth weight infants, where the mother keeps the baby skin to skin on her chest between her breasts continuously until the baby no longer wants to stay in that position and exclusively breastfeeds the baby. Immediate kangaroo mother care is defined as a practice where KMC is initiated immediately after birth. So between the years 2018 and 2020, the World Health Organization conducted a multi-country randomized trial on kangaroo mother care, shortly named the Immediate Kangaroo Mother Care Study. The aim of the trial was to evaluate the impact of continuous mother care initiated immediately after birth, compared to kangaroo mother care that was initiated after the child was stabilized on the survival of newborn with birth weight from 1.0 kgs to less than 1.8 kgs, born in low resource settings. So the trial was undertaken in 5 tertiary level hospitals: Ghana, India, Malawi, Nigeria, and Tanzania. A total of 3,211 infants and their mothers from all centers were randomly allocated. 1,609 were in the intervention group, while 1,602 were in the control group. For babies in the intervention group, skin-to-skin contact was initiated immediately after birth by mothers or surrogate, and babies who were in the control group had brief session of skin-to-skin contact when the mother visited the baby for feeding. So the median daily duration of skin-to-skin contacts was 16.9 hours in the intervention and 1.5 hours in the control group. Neonatal death occurred among 12% in the intervention group, while in the control group, it was 15.7%. The trial proved that immediate kangaroo mother care resulted in a significant reduction in the neonatal mortality. So this is the model of the immediate kangaroo mother care, the wards where we conducted our studies, and you can see the mothers with their infants skin to skin and doing immediate kangaroo mother care. So why immediate kangaroo mother care? Globally, about 15% of newborns are born with low birth weight as a result of preterm birth or intrauterine growth restriction, or both. So up to 70% of the neonatal death occurs in these newborn. These cause of death of low birth weights included respiratory and brain immaturity, hypothermia, hypoglycemia, and infection. Studies have proven kangaroo mother care to be one of the effective interventions for improving survival of the low birth weight infants. The immediate kangaroo mother care trial showed that when kangaroo mother care is initiated earlier, it becomes more beneficial. So what are the benefits of the kangaroo mother care? So we know that there are several benefits of kangaroo mother care, including can help in thermoregulation of the baby, they help in regulating of the heartbeat of the baby, they help in reducing the risk of infections, they create they lower the stress to both mother and baby. They promote breastfeeding and breast milk production. They improve bonding between the mother and the baby, and they increase overall survival of the baby. So, but we had challenges that we faced while we were doing the immediate kangaroo mother care. Some of the challenges that we highlighted were including identification, availability, and preparedness of the potential surrogates in scenarios where the mother couldn't provide kangaroo mother care within 72 hours after delivery. Also, we had shortages of space. The immediate kangaroo mother care ward had only 8 beds, and enrollment has to be stopped when no beds were available. Also, some babies and their mothers overstayed in the immediate kangaroo mother ward due to shortages of beds in the stable kangaroo mother wards. It was a new practice that was not well known to the untrained hospital staff. This led to delays in the initiation of kangaroo mother care. And routine hospital practices, such as systems of admissions, also led to delays in its initiation of kangaroo mother care. So immediate kangaroo mother care and zero separation. As you know, we're aiming at zero separation. So it provided a golden chance of no separation to the newborn with low birth weight and its mother, even when the baby is recovering from possible complications of early life. If routine practice, immediate kangaroo mother care may play a major role in reducing neonatal mortality, especially in developing countries, since it is efficient and cost-friendly. Immediate kangaroo mother care should be made one of the key components of zero separation package. If well practiced, immediate kangaroo mother care plays a big role in reducing the burden of hospital, especially in developing countries, by reducing the duration of hospital stay, need for prolonged use of antibiotics and intravenous fluids, breast milk supplementations, risk for postpartum depression and anxiety. So what are the lessons that we learned while we were doing this, while we were conducting this study? So when hospitals are provided with trained staff and are equipped, then kangaroo mother care can be initiated immediately after birth. Educating the mothers about immediate kangaroo mother care and reassurance are very crucial for the practice to be successful. Mothers can ease the burden of hospital staff by constant watching over the sick newborn and reporting unusual events. So what is our way forward? So tertiary hospitals with high rate of premature deliveries should be empowered to have immediate kangaroo mother care wards. Nurses should be trained on immediate kangaroo mother care, so it can be practiced routinely for babies who are born stable. There should be a global campaign to raise awareness about immediately kangaroo mother care, as many healthcare providers are unaware of it. Thank you very much for listening.
Nilifungua tarehe 2 mwezi wa 7, 2018 hasa mapacha, watoto walikuwa hawajatimia miezi yao. Mmoja alikuwa na kilo 1 na gramu 25, mmoja na kilo 1 na gramu 5. Nilipojifungua tu nikapelekwa KMC, ambayo ni wodi ambayo watoto ambao hawajatimia. Shida ni kwamba mmoja alikuwa hawezi kupumua vizuri, kwa hiyo nilipata ile oxygen ikamsaidia. Huko nikaendelea kukaa nao mwenyewe kifuani, wote wawili niliweka. Kwanza nilikuwa na hofu, ila nashukuru manesi walionielekeza nikaweza kumsaidia mwanangu, nikaelekezwa jinsi kumweka kifuani na kumpa hilo joto. Kama kuna tatizo linatokea unamuita nesi anakusaidia pale. Nashukuru huduma nilipata vizuri. Kwa mimi binafsi nilifurahi kwa sababu nilikuwa nahitaji nijue hatua moja hadi nyingine mwanangu jinsi anavyoendelea. Nikajisikia faraja kwa sababu sikuwa peke yangu, tulikuwa kama grupu la watu wengine. Kwa hiyo tulikuwa tunafurahi. Changamoto zipo kama hivyo, kuna ule uzoefu, lakini kama ndo ushaelekezwa jinsi ya kuwakea watoto, unaangalia kama hivyo, akikaa vibaya unaambia weke vizuri. Basi ni changamoto tu ndogo ndogo. Kwa ushauri wangu nawaambia kina mama njike mioyo, kwa sababu unakuta mwingine anakata tamaa, mwanangu hajatimia, basi sidhani kama yuko sawa, ila wauguzi kukutana nao hana shida, wanakusaidia na mtoto wako anakuwa tu vizuri. Wauguzi wa KMC kwamba juhudi zile walizokuwa natuwekea wagonjwa endelee. Kwa ushauri wangu naomba zoezi hili liendelee kwa sababu inasaidia na imeshasaidia mpaka sasa watoto wana miaka 4 hawana tatizo.
Kwa majina naitwa Wendy Mwagara. Nilikuwa ninafanya kazi hapa Muhimbili kama research assistant katika wodi ya KMC kwa muda wa miaka 2. Taaluma yangu ni nesi muuguzi midwife, na majukumu ambayo nilikuwa nayo katika wodi ya KMC ilikuwa ni kuhakikisha mama anapata huduma, mama pamoja na mtoto ambazo ni stahiki, lakini pia kuhakikisha zile data ambazo zinahusika na masuala ya KMC zipo vizuri. Pia huduma ambazo tulikuwa tunawapa watoto ilikuwa ni kuhakikisha kwamba mama anamweka mtoto skin to skin kwa muda wote ambao anakuwa yupo wodini, na ikitokea ameacha kwa muda mfupi na kwenda kuona na daktari, hapo ndo alikuwa anaweza kumwacha mtoto. Lakini tulikuwa tunahakikisha masaa mengi ilikuwa ni kumweka mtoto skin to skin. Jambo lingine, unamsaidia mama kuweza kumnyonyesha mtoto kwa wakati au kumpa mtoto maziwa. Kwa mimi, kwa utendaji kazi wangu kubadilika, naweza kusema ulibadilika kwa sababu kwa mara ya kwanza tulikuwa tunaijua KMC, lakini kwenye utafiti tukaijua IKMC. Kwa hiyo ni kitu kiliongezeka pale. Utendaji kazi ulibadilika kwa kiwango kikubwa kwa sababu nilikuwa sijui jinsi ya kutumia mashine zingine. Baadhi ya mashine kama CPAP niliweza kutumia nikiwa IKMC. Kwa upande wangu haikuathiri, IKMC haikuathiri chochote, zaidi iliboresha kwa sababu mama alikuwa na uwezo wa kukaa na mtoto muda wote skin to skin, na huduma zingine zikaendelea. Moto zilikuwa ni za mara chache. Kwa mfano, kuna mama alikuwa maybe anaenda kujifungua kwa operation, na mama wengine walikuwa ni wagonjwa, pia tuliweza kuitatua kwa kutafuta surrogate ambaye anaweza kukaa na mtoto kwa muda ule ambao mama atakuwa bado yupo recovery. Changamoto kubwa ilikuwa ni kupata surrogate. Faida kubwa, watoto wengi kupitia hiyo huduma, watu wengi walikuwa wakipona. Pia tulihamasisha ule uhusiano wa mama na mtoto. Na kwa mama, faida kubwa ambayo alipata elimu kuhusiana na jinsi ya kuishi na ule mtoto, kwa sababu bado alikuwa ni mdogo. Wengine walikuwa wakiogopa. Sisi watu wa huduma ya afya tujitahidi kuwapa elimu nzuri wa mama jinsi gani ya kuwahudumia watoto, kuwapa elimu juu ya usafi kwa ujumla pindi wanapokuwa wapo na wale watoto. Nashauri pia wao wanatoa elimu zaidi kuhusiana na KMC. Maoni ambayo niliyapata kuhusiana na huduma ya KMC kwa mama, asilimia kubwa mama wengi walikuwa wanaifurahia huduma na kuwapongeza watoa huduma kwa sababu ilisababisha kwamba watoto wengi walipona.
Naweza kuwashauri wauguzi wenzangu, hasa wale wanaofanyia wodi za KMC, kufanya kazi kwa bidii na kujitolea kusikiliza changamoto za kina mama kwa ukaribu zaidi na kuzitatua. Napenda pia kushauri zile hospitali kubwa ziwezeshwe ili ziweze kutoa huduma hii ya KMC ili kuokoa maisha ya watoto.
Thank you, Naomi, Magdala, and Wendy, for sharing this important study and your valuable experience. It is impressive to see how there was a 25% reduction on neonatal mortality at 28 days in the intervention group. No wonder why these results have shaped the new WHO recommendations for caring for low birth weight babies. The results of this study indicate the need for a global paradigm shift in the care for low birth weight babies. To allow immediate KMC, we need to ensure that mother and her babies are kept together since birth. For those who want to read all the details on the study and the new WHO recommendations for low birth weight babies, please find them in the resource library. I would now want to invite Dr. Barbara Moreno-Sanz, pediatrician from La Paz University Hospital in Spain, who will share her experience on the implementation and scale-up of family integrated care in the neonatal intensive care unit at her hospital. Over to you, Barbara.
Good morning, I'm Barbara Moreno Sanz. I'm a neonatologist from La Paz University Hospital in Madrid, Spain. And today I would like to share with all of you my experience with the Family Integrated Care Model, or as we commonly call FICARE, and the results we have obtained so far. We have published this paper in which we tell our experience from when we formed the working group until we started the pilot study. I will comment step by step how we did it. The burden of adverse short and long-term outcomes in the newborn who suffers prolonged neonatal intensive care unit stay is at least partially related to parental stress and family dysfunction. New healthcare models that focus on the family, the so-called family-centered care policies, have been proposed to overcome these issues. Family integrated care integrates parents in the direct care of their baby as part of the healthcare team and has been shown to have a positive impact on the infant's short-term clinical outcomes, parental empowerment, as well as decreases anxiety, depression, and post-traumatic stress on the families. Up to date, the reports of FICARE model implementation are almost limited to stable preterm infants admitted to NICU. We aim to adapt the 4 pillars of the FICARE model as described by professionals from Mount Sinai Hospital in Toronto to our level 3C neonatal intensive care unit. Our purpose was to scale up the parent training curricula, making it suitable to surgical and non-surgical, non-stable, high-risk infants. This presentation focuses on the FICARE implementation strategy used in our clinical setting and the effort used for its development. 2 potential limitations for the implementation of FICARE were considered: the absence of single family room and the COVID-19 pandemic. That was scheduled as Step 1, co-creation process to define the FICARE implementation protocol and to develop the training program and teaching material. Step 2, which consisted on the internal dissemination strategy among neonatal intensive care unit staff. And finally, Step 3, when we planned to start piloting the FICARE model at our setting to assess its feasibility and to refine procedures before it will be open to all admission once the architectural renovations is finished. Between March 2017 to April 2018, a co-creation process was undertaken by the FICARE implementation team that include nurse assistant, doctors, as well as psychologists and social workers from patient association and veteran parents. An analysis of current procedures for critical care to identify needs, wishes, and requirements was carried out. As a result, the following entry and exclusion criteria to run the FICARE pilot inside were defined, basically covering all patient family dyads for whom more than 3 weeks of admission were expected and have no intellectual or language barriers to understand, providing a decision to provide full leave support was taken, and the family expressed their wish to be included and had signed the informed consent form. A critical point was to attend teaching session for what willingness to spend at least 6 hours per day in NICU was mandatory. A teaching manual was developed that covers both professional and parental curricula with several modules that were identified as the minimum training content to be delivered. Regarding family caregivers, taking part in baby care was categorized into intervention levels, basic and advanced, that cover specific task training for infants who require even more specialist care. A teacher education system was established. The FICARE coordinator defined the mentor-assigned training groups and the calendar. Face-to-face meeting took place along 2 months, reaching 90% of the NICU staff to become facilitators of FICARE. From July 2018 to December 2020, a total of 76 parents and 91 infants were included in the FICARE program. The most frequent neonatal diagnoses of participating infants were prematurity in 75% of cases, followed by congenital heart defects in 14% and different genetic syndromes or congenital defects in less than 5% of the cases, including 2 infants with congenital diaphragmatic hernia assisted by extracorporeal oxygenation membrane. Median infant's age at enrollment was 1 week, without differences between preterm and other complex neonatal conditions. About the impact of COVID-19 pandemic, there were no differences in the number of infant diets included in the program per month. In the pre-pandemic period, fathers and mothers spent a median of 7 and 10 hours respectively with their children, and in the post-pandemic period 5 and 6 hours. Mothers spend more time in NICU than fathers, irrespective of the period that was observed. The family training process relied on workshops and individualized learning by task through face-to-face sessions at cut-size, following an individualized teaching plan adjusted to the baby's clinical condition and the wishes of the parents. In 70% of the scheduled tasks, certification was accomplished within the expected time or earlier. 6 out of 20 blocks of tasks, however, took more time than expected for full accreditation. The feedback on the individual progress reported by either parents or professionals involved in training was used to adjust and refine the work plan. Barriers more frequently identified were nursing staff reluctant to fully adhere the model due to insecurity about parents or own knowledge, transfer of parental knowledge in changing nursing shift, and transition from neonatal intensive care unit to intermediate care halted parental training. Different actions such as grouping patients in the same ward, a standardized template to address the individual teaching plan, continuous education of neonatal intensive care unit staff, and weekly FICARE rounds by responsible person to ascertain individual progress were undertaken to foster FICARE implementation. The satisfaction questionnaire about the FICARE program for families revealed learning material, workshops, and outside teaching sessions as essential for the training. Parents revealed decreased stress and anxiety and will accept to enter the FICARE program again through testimonies like "My answer is yes, 1,000 times yes." This program was determined to learn how to deliver the care that my baby needs. The program allows us to behave as real parents and not mere observation of our baby's life. As conclusion, FICAR implementation in all levels of care in NICU is feasible even when facing two important adverse conditions. One, the absence of single family room facilities, and two, the strict visitor restrictive policies during the COVID-19 pandemic. Even in the case of thorough planning, continuous follow-up, and eventual adjustment according to the current condition to solve difficulties raised by both professionals and families are key elements for the project's success. And now what happened? The Rising Family is a project funded by European Commission through a Horizon 2020 grant. The first objective is to scale up and adapt the FICAR model by including a wider geographical and sociocultural diversity at a total of 7 clinical sites at Zambia, Romania, Turkey, United Kingdom, Netherlands, and Spain. We all have to be able to implement this model in the hospital of the consortium, taking into account the sociocultural differences of each country. The project has been running for a year in which we have known each of the hospital, and we have created all the necessary material to train healthcare professionals and the families. Now we will continue working hard in the next months to ensure that these countries can also benefit from the FICAR model. With this project, I want to show that this is possible in each hospital. It only takes people interested and involved in changing care for newborn and their families. Thank you for your attention.
Some structural and spatial limitation and the restricted family visit policy you mentioned, both challenges that can be applied in MSF settings. I think that using a stepwise approach seems to be a useful strategy that could be used in all settings. Thank you so much for sharing your valuable experience. Next, I have the privilege to introduce Tasmin Botha, a mother and the executive director of Primi Connect South Africa. We're honored to having you here, to hear her perspective as a mother and the impact that zero separation has in the parents of her association. We will all welcome Tasmin. Over to you.
Good day, everyone, and thank you so much for having me. It's such an honor to be here today and engage with you. My name is Tasmin Botha. I am from South Africa, and I am a Primi mom, as well as the founder and executive director of Primi Connect. We are a parent-led organization that provides support, education, and raises awareness for families affected by prematurity. When my middle son was born at just 28 weeks gestation, weighing in at 108 kilograms due to placenta abruption, my whole world was turned upside down. I was thrusted into a world that I knew nothing about. Nothing could have prepared me for what a premature baby looks like. He was literally skin and bones, as fat as one of the last things to develop in utero. I was so scared and did not want to get attached to my baby. I was trying to mentally prepare myself for losing him. However, after a roller coaster 54 days in hospital and many different diagnoses, I was able to finally leave with my baby. I found once I left the safety net of the hospital, I still required support. I went in search online for a support group, specifically South African based, and could not find any. And this is how Primi Connect was formed. When the COVID-19 pandemic hit and countries started going into lockdown, everyone became affected by not having access to loved ones in hospitals. This ripple effect was, and unfortunately still is, affecting the most vulnerable patients, small and sick newborns. I am proud to say that we are a part of GLANCE, the Global Alliance for Newborn Care, which is the global parent and patient voice in the maternal and newborn health arena, representing babies born too soon, too small, or too sick. And we implemented the Zero Separation campaign. Quickly, evidence-based research was conducted to show the detrimental short-term effects of having parents separated from their babies, as well as the long-term effects, some of which will only be seen in years to come. A report was conducted to see just how many families were affected by being separated and what effects that had. And let me tell you, the numbers are astonishing. Overall, 1 in 5 parents, which is 21%, answered that no one was permitted to be present with their infant receiving special or intensive care. 74% indicated that the mother was allowed access, with only 54% allowing the father access. Even in our local context, policies differed from institution to institution, with the majority having zero access. A few allowed for 15 minutes per day, and only 1 parent was allowed to visit in those 15 minutes. Mothers were still expected to provide breast milk during this time, and as you know, breastfeeding rates are low worldwide. The pandemic made it worse. My preemie was born before all of this, and I still clearly remember just how heart-wrenching it was leaving my baby every day. And this was after spending plus minus 10 hours a day with him. So I could absolutely empathize with parents across the world who had zero or limited access to their babies. Even within our own premature community locally, parents were meeting their babies for the very first time upon discharge, or for those who weren't fortunate enough to take their babies home once they had passed. Having your baby born prematurely is in itself a traumatic experience, but not being able to see, touch, or speak to your baby for the first few weeks, sometimes months, or even never at all, is something that should never, under any circumstances, happen. It is an already difficult process trying to bond with your premature baby. There are so many rules, so many regulations, so many risks, as well as all the financial, emotional, and physical burdens you as a parent are going through. I know I was extremely scared to even look at my baby after seeing him for the first time. Nothing in this world can prepare you for that. But by having full access to my baby, by being involved in his care, it not only helped me, but definitely helped him and assisted him in surviving and thriving. Our team was amazing at allowing us to be parents. But not only that, we were at the center of his care. We were treated as an extension of the medical team. They recognized that by having us involved, it not only gave us the confidence that we needed, but helped our baby to thrive. We were allowed to change his nappies and do all his feedings from tube to cup and eventually direct breastfeeding. The research of FICARE, which is family integrated care, shows that it decreases parent stress, results in fewer infections, improves infant growth and breastfeeding rates, and improves patient safety, which was our exact experience. With zero separation, parents are able to implement kangaroo mother care, which evidence-based research now shows should be implemented immediately after birth. When mother is unavailable to do KMC, the father or an extended family member may do so. The first time I was allowed to do skin to skin, my body responded immediately and my breast milk supply instantly increased. As time went on, I became more and more confident and was even allowed to do skin to skin whenever I felt comfortable. It gave me confidence to pick up my baby with all the wires and place him confidently on my chest. We were eventually admitted into the kangaroo mother care ward, and although our stay there was very brief, 40 hours to be exact, it gave me that extra boost of confidence that I required to be able to take care of him on my own. Separation can result in long-term health and developmental issues in newborns and impacts the mental health of parents. I have witnessed this firsthand. Becoming a parent is hard enough, but it's even more difficult when your birth is traumatic, unexpected, and your baby is born too soon, too small, or too sick. Just by keeping mother and baby together, we can eliminate so many and sometimes unnecessary complications. By implementing zero separation, we are keeping parents and babies together, and we are ensuring a better start to life and a better quality of life.
Thank you, Tasmin. I don't have words, to be honest. I have goosebumps in my, very, very emotional. Thank you for taking us through your intimate story. I think your experience illustrates clearly that parents cannot be visitors, but you are essential actors and partners for the care of their baby. So as you say, let's give them a better start in life. Now we'll go to the panel discussion, who will be moderated by Dr. Kirli Polnai, a former MSF nutrition advisor who is currently working at WHO in the Nutrition and Food Safety Department. Over to you, Kirli.
Hello, everybody, and thank you so much for inviting me on to moderate this panel. As Sophie said, huge goosebumps, just so important, all the discussions we've been having. I'm just so happy that we're discussing this in MSF and that we're really sort of pushing boundaries. So we'll be having all our fantastic speakers back to the panel, and also two new panelists will be joining us. We have Livia, who is joining us from Brussels, at one of the headquarters in Brussels, Livia Tampalini. She has been with MSF since 2006 in the field as a doctor, as medical team leaders, as medical coordinator. And since 2019, she's been in HQ and working in the operations covering East African and Haiti. We also will be joined by Honorine, who is a registered nurse, trained in Rwanda, has worked with MSF also for many years, and has been very much pivotal, involved in KMC as her role as a nurse and also as a medical team leader. So welcome to you all. Thank you so much for being here. Now, I'm going to start off with some questions and to our new panelists, just to give our speakers a little rest. But I'm going to start with you, Honorine. Now, you have been working in many countries with MSF in many different projects. So from your viewpoint, how do you see, where do you see we are, in fact, for family-centered care in MSF? Where are we?
So thank you very much. As you said, I'm Honorine. I'm currently medical team leader with MSF. I've been working with MSF for 5 years. I started in Haiti as a pediatric nurse. So I was working in a KMC ward. And I went to Central African Republic as KMC implementer. So where we are now as MSF, so I would like to thank MSF because they gave me opportunity to implement KMC in Central African Republic. It was quite new. So when I started in the two projects, Bosangwa and Ibambari, it was new when I was talking about kangaroo mother care. Some of staff, they were even calling me Mama Kangaroo because yeah, it was a new topic. So when we started, before they were mixing babies and other children. And then we started like separating babies. And after we negotiated with a medical director, because this MOH hospitals, and then they gave us the room. Yeah, but the idea came from MSF. And now where we are now, we have rooms for KMC, at least with 10 beds. And then now we are also in the health centers and the community level, where we are training mothers. So during antenatal care consultations, because where we are in the car, we are referring mothers, they are coming on maternity, yeah, so they have to put babies on KMC when they are being referred. So now kangaroo is being plugged in the community at health centers levels and in the hospital, yeah. That is where we are. So, so now kangaroo mother care is no longer the topic for medical staff only. And now health promotion team, they are trained. So we are also working with mental health team because, you know, when the mother is practicing kangaroo mother care, it takes time. And some of them, they even get like depressed. So we have mental health team, which is like coming every day, passing in a kangaroo mother care ward. So to talk to mothers. Another team is IPC team, where we are like working with mothers. We are doing like sensitization about hygiene, personal hygiene. And another thing also, we are like involving other family members when the mom is seriously sick. So the father can practicing kangaroo mother care or another family member. So it's no longer kangaroo mother care. Now sometimes we call it kangaroo father care.
Perfect.
That is where we are in Nika as like low income country.
Thank you so much, Honorine. And I really love that you're bringing in the importance of the health promoters and the mental health staff, our IPC. We know that we need everybody involved in KMC for any pediatrics or any nutrition project. So that's such an important element, I think. Next, Livia, coming to you. How do you see kangaroo mother care fits with our values as MSF as a whole? How do you see that?
Thank you. Well, of course, for me, this zero separation that it's definitely is fitting with our value. It's when we, as MSF, we want to be a medical organization and we want to see the patient 360 degrees and understand where it's coming from. But of course, imply that the patient is not only a little baby, but his baby is coming from a family. And this is inside of, it's for this that I like this strategy, this idea of zero separation. I think we need to be, as MSF, a pioneer on this, because it's we believe to be a medical organization who is challenging and find a new solution. There are the zero separation and the immediately kangaroo. I think is nice also because it's affordable. It's not only for our following our value, but it's affordable everywhere. And everywhere we can ask the mother to stay with the baby far more than any kind of fancy biomed solution that we can find. That of course were a good solution, but a mother or a father or a family member is far more affordable in the context where we are working. So it's for me it's also important because it will fit in the fact that will shorten the bridge between the medicine that we are doing in poor country and the same medicine that we are doing in other country. And then also wherever we will be, we can propose. I'm not afraid to propose in the middle of nowhere in the same way than in a place where I can find doctor and nurse without issue. So yes, definitely, I think there are so many points that are fitting in our strength, in our capacity.
Thank you, Livia. Thank you. I think that's really, when you were saying about it made me think about the sort of real founding sort of principles of MSF and proximity. And this just reinforces all of that. And that equity aspect, I think we all feel that so strongly, trying to move closer to what we can provide for infants in high income settings and low income settings. And I think that's so important. So next, Barbara, I want to come to you. You did talk about this a lot in your presentation, but sort of tell us again, sort of we've seen that this family-centered approach, it's going to be a bit of a mindset change for quite a few healthcare providers, and a little bit of away from maybe the doctor knows best and the doctor knows what's sort of best for the child, the family. So in your experience, what have been those sort of points of resistance that you felt from some health providers, and how is the best way to overcome these?
Thank you for your question. The truth is that it's very difficult to change how you work with your patient when you have been doing your job for many years. In my unit example, several nurses were reluctant to let her perform some of the typical nursing tasks, and they felt accompanied by them. So,
Barbara, we're losing you quite a lot. You're cutting out quite a bit. I'm just wondering, maybe we love seeing your face. Maybe turn off your camera just for a second so that we can hear you, unless we've lost you completely. Barbara, it's breaking out a bit, but we can come back to you, Barbara, or just try one more time for us.
Okay.
Oh, we can hear you.
Yeah?
Yes, go again.
Sorry. I think that it's very difficult to change your patient.
Barbara, I'm so sorry. We're cutting out. We're cutting out. Save that thought. We want to hear it. I'm going to come back to you, okay? And we'll see if there's anything we can do from our end, but please save that thought. Next, I just then want to come to Naomi. You know, you were involved in this trial. You saw a lot of the healthcare providers being involved, and maybe you had to sort of train some people for the study and for the work. Tell me, what kind of competencies do you think we need from healthcare providers to be able to practice this family-centered care?
So the competencies that we might need, first of all, we need to train our healthcare providers, including the nurses and the doctors and everyone at large, whoever is going to be involved in taking care of these patients. All of them need to be trained, and involvement of the mothers and whoever is going to assist, whether it's the father or their relative who is going to be there, also need to be trained and need to be educated on the importance of family-centered care. And yes, it was a challenge initially, because it's a new thing. You have to educate people, you have to tell people the importance of immediate kangaroo mother care, the importance of involving the mother right from the beginning, the importance of zero separation. But later on, it gained access and people understood and nurses understood. And then it became easy for everyone to partake and help the mothers, and the mothers were free to talk to the nurses, they were free to ask, they were free to do to help the babies, and even the surrogates, whoever came to assist. Initially it was a problem, but later on when we explained to them what we were doing, it became easy for them to accept easily.
Thank you, Naomi, thank you. Jasmine, I want to come to you now, and again, just echoing Sophie, it's so great to have a parent representative here. We're so appreciative, and so many things you said, and also listening to that mother, the video was talking about, I want to know every step of the progress with my babies, and I think that's so important. And what you were saying as well about being sort of too scared to pick up your babies when they're so little. I mean, I've had the same experience with mine, and that fear is very real. You've mentioned this a lot in your talk, but tell us again, because we can never hear this enough. What are those really important elements in that relationship between healthcare providers and parents that need to be there to make family-centered care, to make zero separation happen?
So I think, once it is established that the parents are at the center of the baby's care, that they are not just visitors, it automatically just opens up the gates of communication. And that's what I found in our experience. Like they saw that we were interested, they saw that we wanted to learn, and so it just made it more easier for them to integrate us into the care of our babies. And we were part of the team. I mean, I remember there was a situation whereby as it happens in our country, there was a huge strike. And I was like, okay, if there's no nurses coming into work today, I've got this. I can help them. I can jump in where need be. Because of the education that I was given, because they spoke to me as part of the team. When I didn't understand anything, they would explain it in layman's terms so that I could understand. So we just need to get over that barrier of doctors on one side, parents on one side. Once we realize we are a team, because we all want our babies to survive, we all want the babies to go home thriving. That's the common goal. So as long as we understand that we are not in competition of each other, or that one is more important than the other, I think the way forward looks very promising.
Thank you. That's great. So it's really, you're saying there's that sort of the trust element, really seeing and an equal, really being seen as an equal, being seen as a team. So that seems very, very important. And also, as you were saying, that really important element of explaining things in layman's term, not sort of hearing lots of medical terms and parents not maybe having the confidence to say, I don't know what that means. So that's a really important point. And then leading on that, Barbara, I don't know if you're able to give us a little sound test.
Yes.
Can we hear you?
Here.
Let's try again. Look at Barbara, she's right in the thick of it. She's got her scrubs on, she's in hospital. So just coming back to you again, I've got two questions for you now. You went away and now we've got two questions. So my question for you was about the points of resistance, and that you were sort of saying, we know it's hard changing our ways, but talk to us a bit about that.
Yeah, I was saying that the truth is it's very difficult to change your job, because you have been doing the same job for many years. And for example, in my unit, the main issue was that several nurses were reluctant to let parents perform some of the typical nursing tasks, and they felt examined by them. And some of them didn't understand their role with the family, with that families, and with the family integrated care model. For this, it was essential to carry out an initial training and also an annual training to refresh the importance of the parental participation in the care of their children, and how we can guide their families and their training as facilitators. Because it's important to explain that we are facilitators for the families, and that our work continues to be very important, but the role is changing.
Thank you so much. But I'm going to keep you, because we've got you again for another question, which I think is really, I think you'll be able to talk to us about, and especially seeing how you were talking about having mentors. So, we've talked about the training, but how? What's the best way? We know sometimes, didactic training and your PowerPoints, but how do your mentors help? How do we have that sort of bedside approach? How would we bring that?
It depends on the unit of the group of people, but in general, I think it's a good option. The first part of the training, a theoretical part, like e-learning or similar, and after prepare different face-to-face sessions to discuss the doubts or the different questions about that training, because it's important, the communication between the different people, and is the essence of the family integrated care. For example, in my unit, we are doing every year a refreshing of about the training. Now with the Rising Family Project, we did e-learning, and after that, face-to-face session to discuss about that.
Thanks, that's great. That's really, so e-learning reinforced with sort of face-to-face learning, that's fantastic. So Livia, coming to you, putting your operations hat on, I'm sure you're listening to this and thinking some of this is great, but what are the sort of barriers as well? Or what are these obstacles that you're thinking, could we do this here? Could we do this there? What's coming to your mind in terms of barriers? And then of course, I won't let you off, because then I want to think, what are then a few solutions to those barriers? Oh, Olivia, you've frozen. But she's frozen with a nice smile, which is always good. I shall then...
For us as
you're back. Olivia, we lost you for a minute, so just give us the last sentence back.
Sorry. I was saying that first of all is a knowledge, because we have to do like the other hospital in the world. As MSF, we are a medical organization, and we have to be sure that all our medical staff is aware and is trained of this. So this, and I'm not so sure that we are doing. I'm less optimistic than Honorine. I'm not so sure that we are really 100% on the zero separation. This I'm quite, I have quite doubt, at least for what I see. I think at least in our mission, we have to improve. I have to avoid. So it's maybe already put me in this panel, push me to study. So this can be one of the solutions, that I will push everybody to study and to force and be trained on this. I'm not able to see how many participants are on this section, but this can be one of the answer to your question, Kirill, to know how many PMR or medical referent or medical coordinator are participating to the pediatric day, not only on zero separation, of course, but this can be one of the solutions for MSF. So like we were saying, training, mentoring, e-learning, coaching is a culture that we have to continue and to build in MSF. And then, yes, the issue for me is that is as usual, we work as a silos, even in MSF. So it's if in the medical department we are speaking about zero separation, but then we have to speak, to involve everybody on Jesus, the ops, the log. I know that in the log construction book, there is already this zero separation. But then when in practical we are going to design an hospital, we have to be ready that this is existing really. That is not only on paper, but in reality we still see little bed, no mother, no space for the mother or the family behind or together. So it's, I think, I'm not so sure. I think we have really to start from far. And for me, the solution is really, first of all, like someone will say, work as a team. And remember that in MSF, we are a team. And if you are not a team, we will not go anywhere. And then really the culture of learning. That is we cannot believe that what we learn when we start MSF is what we still have to do. We have to learn every day, every year. And I think, voila, this is also a nice opportunity to learn. After, for sure, there are a lot of other steps, and definitely starting from the HQ, I have to say. It has to start from there and then going to the team in the field and go away in the other way around, up and down, and right and left, and to see what are the challenges. Because I'm sure definition of family and family approach is not the same everywhere in the world, and we have to adapt in the niche context in a different way. And for do this, we have to listen our team in the field and find our own solution that for sure will not be the same everywhere. But this is, we have to be ready to this challenge. Voila.
Thank you, Livia. I think, yeah, that's, I think as medicine changes, and I think that's really important, isn't it? That we all have to stay up to date, and also to, you know, I think about back to my first mission and how I progressed and changed, and we all have to keep doing that in MSF. My next question is for you, Naomi. And we sort of thought about, well, we talked a little bit about sort of maybe some task shifting. And so it can kind of go both ways, isn't it? And that we don't want sort of, you know, some things that doctors or nurses traditionally did. Like, so what experience did you have in your hospital about task shifting, or not necessarily shifting, but sharing of tasks that can really facilitate zero separation?
So it was a bit of a task initially, because we had to train before starting the project. We had to train the nurses about the importance of zero separation. And initially, because we also didn't have CPAPs, they came a bit later. We also had to train them about the equipment, about the use of nasal prongs. So a lot of trainings had to go with the midwives, with the place of delivery, the labor rooms, in the theaters. And we had also to train the doctors that were also working in the unit. We had to inform them and tell them about the study, and we had to tell them about the importance of zero separation and importance of babies undergoing treatment while they're on their mother's skin to skin. So eventually, with time, people started understanding. Initially, it was difficult. People were scared, but later on they understood, and then they felt, okay, so this can be done. A baby who is sick can stay with the mother or the surrogate and still receive the same care that was needed initially. And if the baby was very sick, needing further care, yes, we would separate for that particular time, and later on she or he will return to the mother. So it was kind of a hard task, but later on we got the move of things.
Great, thank you, Naomi. I want to talk a bit about the continuum of care. So Honorine, you mentioned this a bit, but talk to us a bit about and how your experience have been of trying to implement zero separation, or even in KMC at a sort of community level in health facilities or beyond. Tell me a bit about the work you've been doing there.
I'm sorry, what we are doing now at community level? I'm sorry.
Sorry, that was for Honorine. Barbara, I will hear from you later, but first Honorine, and then I'll come back to you, Barbara.
Yeah, so now what we are doing?
Yes, in the community, you talked about it a bit just earlier on, but so just tell us a bit about how you really managed to get this, not just in hospitals, but as in health facilities or sort of in the community. You know, what's made that work and what has made it not work?
Yeah, so as I said, I was implementing zero separation in a hospital, but we were receiving many premature babies and the other babies, of course, who were coming from the community. So we don't have cars in a rural country, in a low income country like car. So we have outreach team, we have a health promotion team. We trained them as, of course, we are working as a team. And because the team of outreach, we have nurses, we have midwives, and now they trained the community, traditional birth attendants. So they are the ones who are still referring babies. Of course, we are facing many challenges. Many babies are dying on the way to the hospital, but at least when we started comparing where we are today, at least we are saving 70% are surviving. And we always evaluate, at least every month, we evaluate where we are and where we want to be. Yeah.
Thank you, Honorine. I think it's a bit of a reminder, you know, that lots of these kids are dying on the way, but the fact that you are trying is fantastic. And then Tasmin, talk to me a bit about what are the differences in messages, or what are your different needs when you're in hospital versus having this kind of zero separation support at home if somebody's coming to you, or you're just going to sort of a more of an outpatient setting. What are your needs there, and what do you maybe see we need to do more of at that level?
Definitely, you know, prematurity is such a taboo subject still, unfortunately. So education is definitely key. Knowledge is power. If everybody on the ground understands the risks involved with the preterm child, you know, just general hygiene, simple things like that makes the journey at home so much easier. You know, when I think about when we were discharged, we went into complete isolation just because we were so afraid of bringing our premature baby into contact with people. And people were so very, very stubborn with regards to educating themselves, respecting our boundaries, our needs, simple tasks like washing hands and sanitizing, not coming around when you're sick, were such challenges for us back then. And I feel like the more we educate people, the better it will be, because I've seen the shift now. I mean, the COVID pandemic, as terrible as it was, actually opened a lot of minds to simple tasks like washing of hands and sanitizing and not coming around when you are ill, because of the detrimental effects it can have on a child that is born prematurely. So, I mean, at antenatal level already, would be nice to inform the parents, should you have a preterm child, this and this and this should be put into place and should be done once you're home, because like we're saying, like the mortality rate post-discharge is so high, and I honestly believe it's due to lack of education.
Wow, that's so interesting. And when you were saying about this sort of education, it kind of goes then beyond even sort of health facilities or even the family, because you realize it's your family and your friends who needed the education. And so if you kind of, what would be the best tool that you want of educating those people around you to your needs and about the sort of the realities, the do's and don'ts of premature babies? What would be the most useful thing if you could kind of have it today in your hands? Is it an app? Is it a TV program, radio program? Like what do you think would be useful, or a little information thing?
I think it would differ from place to place, just because access is so different everywhere. Like it's easy to say, oh, an app, but like, you know, in Africa, getting data or even having smartphones is not very accessible for many people. So I feel like a lot of people definitely, they go to clinics. We have to go to clinics for checkups. So let's start there. Let's have a pamphlet, a brochure, people coming in to give talks. I mean, I was very, very impressed with my last pregnancy, that they did speak about premature birth, that they did educate about some signs and some symptoms, because we know that premature birth, you know, it's up and down. It's not one size fits all, but to at least know, okay, there are indicators, you know, if my blood pressure is too high or things like that. So if we can just let people know from ground level, like this is a thing, it's a real thing. Prematurity is affecting so many people. And we've seen an increase, you know, through this pandemic as well. So if we start just at the bottom and work our way up from there, we can go into fancy advertisements and stuff, but let's start with clinics handing out information. I like how Honorine was saying that they had outreach programs in the community. That would be great. You know, finding out about prematurity when you have a premature child is not the ideal situation. I would have loved to have had information prior, you know, like my premature birth was a very, very unexpected, as is most. And then you thrust it into this world that you just absolutely know nothing about. And I mean, I'm 5 years into this premature journey, and I can tell you till today, I'm learning every day new things about prematurity. So if we can just provide tools and access and education. I mean, I know it's easy for us. We can go onto a phone, we can go onto Google, we can type in some, but not everybody has access to that. And we need to make it easier. And so that we can also educate the generations before us, because they are also very resistant, especially in the African context, like our grandmothers and great-grandmothers who end up being the primary caregivers in a lot of circumstances. They don't want to hear about these things. So we need to be able to educate them as well in a manner in which they would understand that, you know, if you do A, it's going to lead to B. We need to not do, you know, these type of things. So yeah, we just need to educate and start at the grassroots level.
Thank you. That's a really powerful message. I hope everybody's listening out there. Now, we're going to go now to some of the questions that are coming from our audience. Lots of great questions coming in. Thank you so much. Keep them coming. We will try to answer as many as we can. So one of the first ones that's come in that everybody's very interested in is IPC, of course. So infection prevention and control. Barbara, let's start with you, and then I'll ask the same question to Honorine. But did you get pushback from IPC? You know, how did you address that issue? And sort of what were the things you did or the discussions you had that helped?
With family integrated care, we have demonstrated that we have less infection when the parents is the main caregivers of the babies. obviously, the healthcare professionals, we are very, very worried about the infection. And many people think that it's worse if the family is included inside the neonatal intensive care unit, but it's not true. The truth is that there are less infection when the families are inside our units. Obviously, they have to learn about the hygiene, and they have to learn about what they have to put, to dress. But obviously, we can't forget that our patient is not only the baby, it's also the family. If you take account the family also is different, and in the infection is aware of the objectives in this type of model like family integrated care.
Thank you. That's really interesting. So infection rate is lower when families are involved. I think that's a really important message here. So the same question to you, Honorine. What discussions have you had with your IPC colleagues? What have been the sort of difficult discussions, and then the sort of agreements that you've come to be able to carry out zero separation, family centered care, and KMC in particular?
Yeah, thank you. So for us, we worked as a team. We included everyone because it was new. Even we had the support from ops, the PC, logistic, and what. So for us, yeah, what we did, we trained everyone first, the guards, medical staff, logistic team. And then it's not everyone who is like allowed to enter KMC ward. Yeah, so we have the guard who's controlled the movement, and we have also dedicated team for cleaners and hygienists who are trained in IPC. The same for medical staff. And then we even requested, the dress code for mothers. We have dress code for babies who are in KMC. And then we have, to clean the ward at least 3 times a day. So we have instruction for KMC. Of course, we had challenge because it was like starting from the scratch, It takes 3 months to convince people how to behave, that we don't have to enter the ward KMC with our own shoes because there was clothes dedicated for KMC. But now I would say that we are at least at 80%, and then we continue to reinforce sensitization. We are working with health promotion team. We have a health promoter dedicated for KMC ward who is sensitizing everyone. Yeah, wash your hands. Even it's not only for mothers or like visitors, even for medical staff, we have always to remind them. Yeah.
Thank you, Honorine. I think you're reinforcing as well what Livia said, the importance of being a team. Now, one question which has had lots and lots of likes, and it makes me hope that we've got some logistics people watching, but is how do we, so I'm going to ask this question, Naomi, to you first. How did you involve, the logistics or the facilities people in your hospital to help with creating a space that you really could do zero separation of KMC? How did you talk to your logistics colleagues?
Yes, so in our facility, there was a room that was given to us once we told them the importance of zero separation, and once we told them about the study, and once we educated everyone, so a room was allocated for us. In that room, we had 8 beds, and there were 8 CPAPs, and then we were able to recruit mothers, but then since it was a randomized control trial, we had to first consent, and then they were given a card. It all depended on what arm they were going to fall on, and then they were recruited consecutively. So we had a good support from the head of the hospital who gave us that room, and then it was renovated, and then the space fitted what we wanted to do for the study. And truly, we saw great reduction in mortality, and even hypothermia had improved, because we were taking these babies as the time they were born in theater, the time they were born in the labor rooms. We had already educated the surrogates, even though there were times they were not understanding. Being in Africa, they had so many notions, but later on they understood the importance of taking care of these babies right from when they were born. So we saw there was a reduction in hypothermia rates, and then there was a reduction in sepsis, because we educated them again about the importance of IPC. And at the same time, the survival rate had also increased in the first 72 hours of all the babies, and even though at the end of the study, which was 28 days follow-up.
Thank you. That's really interesting. So maybe we can sell the idea to our logisticians by saving on heating bills, maybe. But just Livia, coming to you, put yourself in the position being a project medical referent, or being, a medical team leader of a project. Tell me the discussion you're going to have. You're going to knock on the door of the logistics office. How are you going to sell this? How are you going to get them involved?
Well, first of all, I think it depends when in the project we are, in the history of the project. If you are at the beginning, so in the construction moment, or if you have to make big changes. Because I think these are the important things to remember. At the beginning, I think it's in one side is easier, but it's a big, because usually we sit together and we speak and we make a plan and design, and it's easier to have a better flow of patient, a better organization. If you have to make a change, it's, well, first of all, it's always, again, is a teamwork. An hospital meeting cannot be only the medical team. And this will never work. This we have to be clear. It's to be, and medical doesn't have to be only doctor and nurse. It has to be HP, it has to be mental health, and everybody is convinced. But I think it's, for me, it's clear now that we were doing the same this discussion for an hospital in our project, and I think if the people doesn't see what we are speaking about, they will not follow. Once the log, in my experience, once the log understand what you want to do, then the things is done, and maybe you will find even better solution than what you were thinking as a medical team. So just really explain. A picture for me was already easy, or when I ask explication about what is really zero separation, I was trying to challenge and say, okay, even this child, yes, even this child. So for the log has to be the same, has to understand all the children, yes, almost all the children. So it's okay that you have you need a big bed and voila. But this is together, and don't be scared. Don't scare the people to make the stupid question. I think this is also the key of the explication. I was not afraid, or not too much, to ask the stupid question when I ask give me the explication. So it's I think it's the same for everybody. It's allowed everybody to make the stupid question, and then we will be a team who understand.
Thank you, Livia. There's no such thing as a stupid question. And I think that's a really important element for our logistician colleagues, for our supply colleagues, is come with the problem. Don't always come with what you think the solution is going to be, because sometimes other people will be thinking in a different way, and maybe kind of out of our little medical bubble, they will come up with better solutions. So another question, which is a really interesting one. So I'll ask this one first to Barbara, but then I will come to you, Naomi, as well from the study, is that if this approach has had any effects on the rate and sort of nature of perinatal or postpartum mental health outcomes. So I don't know if, Barbara, you've managed to capture that information, or just even anecdotally from the people you've worked with. What's been your experience?
In my experience, the families who can care their babies, they are very, very happy. They have more confidence, and they are prepared to go home, because they have studied, they have trained, and they are prepared for that. And obviously, if you explain everything around the care of their baby, they are more relaxed. The depression and anxiety is lower, and that's important in this type of units, because it's very, very stressful to have a very sick baby or a very premature baby. And we have to try to avoid that psychological disorders. And if you can achieve only include the families, that's great. It's easy.
Thank you, that's great. And Naomi, I'm not sure if that was collected in the study or not. You have to forgive me for not having read that part, but did you collect anything on sort of quality, the experience of families, or even sort of any effects on postpartum depression or mental health status in your study?
No, it wasn't collected, but the few mothers, I mean, most of the mothers we spoke with at the end of the study, whenever they were being discharged, whenever we asked them, they were really happy. They enjoyed the fact that they could be with their babies. They saw everything that was happening to their babies. They understood the treatment that the baby was taking, and it was easy for them to explain even to their relatives of what was going on. And we saw that it gave them like a calming effect compared to the control group, because we would go and see, they would come in hours, like every 3 hours or sometimes every 6 hours to come and see their newborn. But these ones, and the control group would sometimes say, I wish I was also in the other arm where I could stay with my baby all the time. So really, we saw a great improvement and a great calmness. And I think because they could initiate breastfeeding early, they were able to do everything for their babies. Yeah.
Thank you, Naomi. That also speaks to this element I did see from your study that was actually stopped early because there were such important benefits. And it makes me think of you saying about this sort of the mums in the control arm, how difficult that must have been. Another question that we've had in is about the surrogates, which I think is very interesting. A few people have mentioned them, but I wanted to start first by putting this to Tasmin. How would you feel about somebody else doing this, about somebody else doing the KMC? I know it all depends on who it was, but you know, and how would you feel, Tasmin, about somebody else giving that care to your baby if you weren't able to?
Well, knowing what I know now, obviously with the information that I've received, absolutely I would allow somebody else to do it because the benefits are just so great. But obviously that would need to be explained. You wouldn't just want somebody, here's the baby, you know. But yeah, if the benefits were to be explained and you knew that was the best for your baby to survive and thrive 100%, I would definitely allow it.
Great, thank you. And Honorine, coming back to you with your kangaroo father care, tell us about how you've involved surrogates, including fathers, in this process, and what did you know, what was the best way to get them involved or get them to accept it, and obviously the mothers as well to accept it?
Yeah, so first of all, you have to know that the context where I was, you know, the mother is always coming with the father. Yeah, most of mothers, they are coming with the fathers. So when the mother is seriously sick, or maybe the mother has twins, yeah. So we started like explaining to the father the importance of kangaroo mother care. Yeah, the importance of zero separation. And then I would say like 90% they accepted without hesitating. And I said before, we even included the mental health team. They were talking to the father and to the mother because of culture barriers. When they will see the father, like, you know, carrying baby on the chest, what they will say? Yeah. So, but the mental health team helped the team, the medical team, yeah, to handle that issue. And the fathers, I think, even if I'm not there, they are still practicing kangaroo father care. And we also like asking them the consent to take pictures, and we have like some pictures in the word, and sometimes we even show the new fathers, look here, you are not the first one who is doing this. And we are also, we are doing the same for mothers. We have many pictures, we show the mothers, look, the previous ones, they did this and then baby survived. So can you do this also? Yeah. We are taking pictures before and after when they are coming back for follow-up. Yeah.
That's fantastic. That's a great idea. I really like that those pictures ideas. Now I'm gonna have one question, and then I'm gonna from the audience, and then one final thing I'm gonna put to Tasmin. But this is a lovely question here, which gives us the spirit of debate in MSF, which we know is everybody loves. So this is this. Given the clear benefits of keeping mothers and babies together, we might wonder, why did we ever separate them in the first place? Should we even do neonatal care if we are not able to keep mothers and babies together? Now, of course, I'm just going to ask that hard question to Livia. She knows that was coming. So Livia, should we even be doing neonatal care if we cannot keep mothers and babies together?
I will answer with a question. Why we should not be able to keep together?
Very good. You can see she's
I get it. I mean, it's a question of space, but we are in MSF, so we cannot attend. And I think then the fancy part will. It's for this that was what I was saying. That for me is quite sustainable as a part of the project. So the question can be what we are not able to add as additional care to the baby, oxygen or additional things. That this is okay, but this is always the question. But keep the baby with the mother or the father. It's a question of space only, and anyway, you will not kick out them of the hospital, I hope now, and then it means that are somewhere in our compound. So I think it's only here in the mentality, and for me it's a question, and it's for this it is important that we change. But the reason is only why we don't have the space is because we didn't put it. Yeah. Only this.
Well, I like that. Why couldn't we keep them together? Now, just want to say a big thank you to all the panelists, but I do want to have one last thought from our mum, from Tasmin. Tasmin, if you literally had one sentence that you just wanted to leave this session and for MSF, what's the one short sentence, but the powerful message that you want to give to MSF and to everybody listening to this? No pressure.
Definitely that by keeping babies with their parents, they will survive and thrive.
That's enough for me. That's fantastic. Thank you so much, Tasmin. Thank you to all the panelists. We really appreciate your thoughtful answers, and we really think you've given so much food for thought. So I will close our panel discussion and hand back to Sophie. Thanks so much, everybody.
Thank you, Kirli, and thank you all the panelists. I'm really speechless. I'm super happy to hear that Operation is saying there's no way we cannot do this. We need to find a way to do this. Thank you, Livia, for representing the operational aspect of MSF. So I have the big job of trying to summarize quickly the main messages of this session. So I think it was clearly during the panel discussion, during the presentation, that one, mothers and babies needs to be together right from birth. With a zero separation approach, we will revolutionize the care we provide to newborns, because it will allow us to implement a life-saving intervention such as immediate kangaroo mother care. We saw that there are many opportunities to implement zero separation along the continuum of care. Family-centered care leads to better health outcomes, improve experience of care, and empower families. We have seen it and heard it from Tasmin Bota. However, we still have a long way to go in our fields. We need a cultural shift. We need trainings, but not only trainings, we need to change the way we perceive the problem. We need to involve all stakeholders to ensure a successful implementation of family-centered care and zero separation concept using different strategies. approaching the different challenges that we'll raise from a multidisciplinary perspective, not only from the health staff, but also from other profiles. We heard that logs, HR, admin, community engagement are important. And finally, we need to engage with mothers, with families and communities to really overcome the problems when they come. We have heard that there is fears and resistance from health staff on the risk of increased infection, which are unfounded, because we have heard that the latest evidence show that infections are reduced when mothers and babies are involved in the care. So finally, let's remember, mothers and families are not visitors. We need to open the gate, as Tasmin said in her presentation. They should be active actors and partners in care. Let's give the most vulnerable patients the best start in life. Please spread the word and let's all start the change together. We need to start changing the way we see the problem. Thank you all. Thank you for the panelists, for the people behind the scenes who made this session possible, especially thanks to Ana de Lozada and Marge Hodges, the SRH working group, and everyone for listening. Thank you. Back to you, Myrto.
Wow. Thank you. Thank you to everyone. Thank you, Kirili. Thank you, Sophie. And thank you to the entire team on the panel, all the presenters. This was just amazing, absolutely amazing. And yes, I hope this is just the start and it will not just be an amazing memory.